Clinical presentation and management of gas gangrene. Gas gangrene, or clostridial myonecrosis, is a life-threatening soft tissue infection caused by anaerobic, spore-forming bacteria of the genus Clostridium, primarily Clostridium perfringens. This condition is characterized by rapid tissue destruction, systemic toxicity, and gas production within infected tissues. Clinical presentation. Gas gangrene typically occurs after trauma, surgery, or in cases of ischemic tissue. It may also occur spontaneously, often in patients with underlying vascular or metabolic conditions. 1. Local symptoms: severe pain, sudden onset and disproportionate to the appearance of the wound. Swelling and edema, rapidly progressive in the affected area. Skin changes: pale skin progresses to dusky, bronze, or purplish discoloration. Formation of hemorrhagic bullae. Crepitus: palpable crackling due to gas within tissues, though not always present. 2. Systemic symptoms: fever and tachycardia, early signs of systemic inflammation. Hypotension and shock, progression to septic shock is common. Toxic delirium, confusion and altered mental status due to systemic toxicity. 3. Laboratory findings: leukocytosis, elevated white blood cell count, elevated C-reactive protein, CRP, and procalcitonin, markers of severe infection. Metabolic acidosis, low bicarbonate and elevated lactate levels. Hemolysis, anemia due to toxin-induced red blood cell destruction. 4. Imaging: X-ray or CT scan, presence of gas within soft tissues. MRI, helpful in defining the extent of tissue involvement. 5. Microbiology: Gram stain of wound exudates typically reveals gram-positive rods without neutrophils. Cultures may isolate Clostridium species, though treatment should not be delayed awaiting results. Management. Gas gangrene is a surgical emergency requiring prompt and aggressive management to prevent mortality. 1. Resuscitation and supportive care. Fluid resuscitation. Administer crystalloid solutions to manage hypovolemia and shock. Hemodynamic monitoring. Vasopressors may be required in cases of refractory shock. Pain management. Effective analgesia for severe pain. Monitoring. Intensive care unit ICU admission for close monitoring of vitals and organ function. 2. Empiric antibiotic therapy. Initiate broad-spectrum antibiotics immediately. Combination therapy: penicillin G or other beta-lactam antibiotics for Clostridium coverage. Clindamycin inhibits toxin production and has anaerobic coverage. If polymicrobial infection is suspected, e.g. in diabetic wounds, add vancomycin or linezolid for MRSA, metronidazole or carbapenems for additional anaerobic and gram-negative coverage. Wound 3. Surgical management. Urgent surgical debridement. Remove necrotic and infected tissue, often extensive and may require serial debridements. In severe cases, amputation may be necessary. Wound care. Ensure proper drainage and monitor for secondary infections. 4. Adjunctive therapies. Hyperbaric oxygen therapy, HBOT, used in some cases to inhibit anaerobic bacterial growth and improve oxygenation to tissues, not a substitute for surgical debridement. Antitoxin therapy. In rare cases, antitoxins may be considered for toxin-mediated diseases. 5. Post-operative care and rehabilitation. Monitoring for recurrence, frequent wound inspections. Nutritional support promotes wound healing and recovery. Psychological support and rehabilitation, especially critical for amputees or those with significant tissue loss. Prognosis. Without treatment, gas gangrene is almost universally fatal. Even with optimal care, mortality rates range from 20 to 30%, especially in cases with systemic involvement. Early recognition and aggressive intervention significantly improve outcomes. By understanding the clinical presentation and instituting timely, multidisciplinary management, the severe morbidity and mortality associated with gas gangrene can be mitigated.